Thank you. It's always an honor to be at this conference and see all of you here. And it's also very timely that this talk falls after Dr. Hoffman's talk, because I do think that intellectually there is two dots to connect in that regard. So I'd like to talk to you today about the trial that we completed, and it's still ongoing, with regards to Eplerenone for the early cardiomyopathy and Duchenne muscular dystrophy. Dr. Subha Raman is the principal investigator in this trial, and she was going to be making this presentation today, and unfortunately she wasn't able to attend, so I will try to do my best in her absence. Oops. Jumped. Okay, so today I'd like to talk to you a little bit about what we're going to here is, first I'll give you a little background on Eplerenone. I'll talk to you a little bit about cardiac MRI as an important endpoint for this clinical trial. I'll present some preclinical mouse data collected from Raphael Fortney, who spoke to you earlier in the conference. And then present the results of our trial and let you know what's next. So Eplerenone, as we've learned from Dr. Hoffman, is an aldosterone antagonist and a potassium-sparing diuretic, which means a diuretic means that it helps the body to get rid of water but maintain potassium. It's used in the management of chronic heart failure in both children and adults. It's marketed by Pfizer under the trade name of Inspira, and it's similar to a very commonly used drug that some of you may know or may be on, Spironolactone. However, Eplerenone is more selective for the mineralocorticoid receptor than spironolactone, and what that means to you all is that it has less undesirable side effects. And one of the side effects of spironolactone in boys is that they can develop gynecomastia, or breast development, which obviously is an undesirable side effect. And that's because it doesn't possess any anti-androgen or estrogenic effects. So what is aldosterone? Aldosterone, as Dr. Hoffman referred to, is a steroid hormone in the mineralocorticoid family, and it's produced by the adrenal gland in the outer section of the adrenal cortex. And it plays a central role in the regulation of blood pressure. It acts by increasing reabsorption of electrolytes and water in the kidney and results in the conservation of sodium, excretion of potassium, which then increases in water retention and increases your blood pressure and blood volume. When it doesn't work and it's dysregulated, the aldosterone becomes disease-causing and contributes to the development and progression of cardiovascular and renal disease. So, aldosterone, when dysregulated, has many negative side effects, including cardiac fibrosis and remodeling, progressive renal disease, edema or swelling, cardiac rhythm abnormalities, thrombogenesis or clot formation, and also vascular injury and fibrosis. So how do we want to deal with this? Is we want to use an aldosterone receptor antagonist. And these prevent the negative effects by blocking the aldosterone receptor. These receptors are overexpressed in the failing heart, and these mineralocorticoid receptor antagonists will also likely affect other important heart failure pathways, which are not well elucidated at this point in time. So two commonly used aldosterone blocking drugs, or aldosterone receptor antagonists, include spironolactone, which we've already discussed, which is a selective aldosterone receptor antagonist, but it does have side effects due to its binding to other steroid receptors. And Eplerenone, which is the first agent in a class of drugs known as selective aldosterone receptor antagonists, or SARAs. And the good thing about this, and the thing that I think is important for all of us, is that this is a drug that is in common use today. It's used in a large number of patients, the adult heart failure population, patients who've had myocardial infarcts. So it's a drug that is available at this time and is commonly used in other patient populations. So aldosterone antagonists have a long record of success. And spironolactone has been in use since the 1960s, with Eplerenone more recently coming to market in the early 2000s. Here's just a little bit of data from a trial that was published in the New England Journal of Medicine in 2011 looking at the adult heart failure population. And I just included it to show that Eplerenone had benefit in that patient population with regards to death as well as hospitalization for heart failure. So Eplerenone is thought to be safe. It does, however, potentially increase the potassium levels, especially if kidney function is abnormal, and this must be monitored for because increased potassium levels can potentiate significant rhythm abnormalities, which can be life-threatening. But its general safety, if appropriate monitoring is undertaken, has been established in both pediatric and adult patients. Now we're going, the slide's a little busy, but I thought that it was really important to include all of this because I think in order to understand why this trial or how we impacted cardiac function in this trial, that it was important to understand how the MRI works. And so the body consists of water. Both hydrogen ions and oxygen ions are in water, which consist of protons. And these protons act like tiny magnets and are sensitive to magnetic fields. And in the powerful magnetic scanner, the protons line up in the same direction in the same way a magnet can pull the needle of a compass. Here's the important part that you sort of need to hang in there to understand, but short bursts of radio waves are then sent to certain areas of the body, which then knocks these protons out of alignment. When the radio waves are then turned off, the protons realign, and in doing so send out radio signals, which are picked up by receivers in the scanner. These signals allow us to distinguish between various types of tissue because the protons in different types of tissue realign at different speeds and produce different signals. In the same way that millions of pixels on a computer screen can create complex pictures, the signals from millions of protons in the body are combined to create a detailed image of the inside of the body. So an MRI is like a big radio tuned to hydrogen, and that's sort of how an MRI works. Now, why is that important? Because MRI allows us to see things in Duchenne muscular dystrophy beyond the image quality that we can see in previously. The standard with regards to imaging was an echocardiogram or a cardiac ultrasound. So few histopathological studies exist for what myocardial enhancement by late gadolinium enhancement, or LGE, presents in Duchenne muscular dystrophy. And so what we mean by this is that when you do a cardiac MRI, we give the patient IV contrast material, and this contrast material lights up the myocardium. And you can see in the MRI image there that I've outlined with a red arrow an area where we're seeing the myocardium light up. Now, what this means in Duchenne, I think we somewhat intellectually understand, but not for sure. So in other non-ischemic cardiomyopathies, other cardiomyopathies from other causes, we usually see this lighting up in the mid-myocardial area, which we do felt corresponds to fibrosis. But this epicardial, or this lighting up of the myocardium on the surface of the heart in myocarditis, or inflammation of the heart muscle due to infection, is thought to represent an inflammatory infiltrate. So the consistent lateral wall epicardial enhancement that we see in Duchenne is identical to the myocarditis pattern, which suggests that the myocardial damage detected by this means might include an inflammatory component. And this is supported by preclinical data in the mice. So is there an inflammatory process that starts, followed by fibrosis in this patient population? We're not sure, but it's telling us a lot about what's going on in the heart muscle, and it's somewhat of a useful tool. So we can see heart muscle damage with cardiac MRI before the ejection fraction falls. And here we have a picture of a cardiac MRI where we have, you can see the detailed images that we can get as a result of this modality. And there we once again have a patient who's received gadolinium, or the dye material, and we can see the myocardium lighting up with where the yellow arrows are. We also, you can use cardiac MRI to measure myocardial strain, which is essentially, it's a very complicated concept, but it's essentially a measure of contractility. And what we have found in this patient population in studies previously done by one of my colleagues, Dr. Kanhor, is that as the patient ages, there are myocardial strain abnormalities that occur. And we can potentially use this as a biomarker in this disease. In order to get myocardial strain, we need to modify the images in a fairly sophisticated way in a process that is known as tagging. So now moving on to the preclinical mouse data from Jill Raphael Fortney. She looked at the use of spironolactone and lisinopril in the het mouse, which is a dystrophin deficient and is also missing one copy of utrophin. It's known for its severe skeletal muscle fibrosis and a cardiomyopathy that progresses similar to DMD patients. In her study, she treated the mice with an ACE inhibitor as well as an aldosterone antagonist. She had some mice that were untreated. She had a group of mice that started treatment at 8 weeks of age and mice that also started being treated at 4 weeks of age. And then at 20 weeks of age, she analyzed the data by looking at cardiac MRI on the little mice and also doing some other functional assessments. So at 20 weeks, there was preserved ejection fraction despite extensive myocardial fibrosis and injury, and which is important to know, so that if we were to just have looked at the mice based on function, we wouldn't have seen any significant difference. However, myocardial strain was abnormal, and strain improved with treatment of the mice at 8 weeks, and there was more marked improvement seen at 4 weeks. So the bottom line from this was that the earlier that we seemed to treat the mice, the better they were at the end of the study. This is also from her paper where in the pink panels at the top, you can see that at the het untreated mice had a significant degree of fibrosis, as you can see the scar tissue there, and the mice that were treated at 4 and 8 weeks had significantly less scar tissue seen on pathology. It's also important to note that there were changes noted of benefit in the skeletal muscle as well. And this just reinforces that concept. So now moving on to the trial that we performed in the young men. It was a multi-center, randomized, double-blind, placebo-controlled trial. It was performed at 3 centers: Ohio State University, which is Nationwide Children's Hospital, Cincinnati Children's Hospital Medical Center, and the University of California in Los Angeles. All visits occurred between March of 2012 and July of 2014. The study was essentially pretty simple. With regards to a cardiac MRI was obtained at baseline and at 12 months, with follow-up visits at the study site at 6 and 12 months, and safety labs drawn, as well as other additional laboratory studies looking at inflammatory markers and other markers. So to be enrolled in the study, the boy had to be 7 years of age or older with evidence of some fibrosis on cardiac MRI. The ejection fraction had to be greater than 45%, and the boy also had to be on an ACE inhibitor or an angiotensin receptor blocker. And they were randomly assigned to receive either Eplerenone or placebo. 42 patients entered the study, 20 were randomized to Eplerenone, and 22 were randomized to placebo. With regards to safety and adverse events, we didn't have any boys that had significant hyperkalemia, and all continued to have stable kidney function throughout. There were no deaths in those randomized to Eplerenone. However, unfortunately, there was one death in the placebo patient arm due to a fall fracture and fat embolism. So what did we measure? Our primary outcome measure was a 12-month change in left ventricular circumferential strain, and we felt that a 1% change in strain units was considered clinically significant. Some secondary endpoints were a change in the left ventricular ejection fraction, We also measured LV systolic and diastolic volumes. We looked at the change in the extent of this fibrosis by injecting gadolinium. And we looked at blood biomarkers, including creatinine kinase, the MB fraction, troponin, and osteopontin. And I'm going to talk a little bit more about osteopontin because it will prove to be statistically significant in our study. It's a cytokine-like protein with a central role in tissue injury, particularly inflammatory myocardial damage. So at 12 months, we didn't see any significant changes in the degree of fibrosis. And fibrosis imaging on cardiac MRI is very difficult to quantitate, and it's a very qualitative measure. And what that means is the person who's reading the study assesses it visually. There are methods that are being developed to try to quantitate fibrosis, but they're not readily available at this time. We also did not see any significant change in blood biomarkers of myocardial damage. But what we did see was a statistical difference in the 12-month change in plasma concentration of osteopontin, and this was associated with a change in the appearance of LGE during this period, which might support the concept of an anti-inflammatory response to eplerenone. We also did see a significant change in myocardial strain, as well as a significant attenuation in the decline of ejection fraction, as I'll show you in the next slide. So we did see a decrease in, or an advantage, a strain change, as well as an attenuation of the ejection fraction decline. So in conclusion, eplerenone seems to provide benefit in an early stage of cardiac involvement in Duchenne. Eplerenone, in conjunction with the use of an ACE inhibitor or an ARB, slowed the decline of function compared with an ACE or ARB therapy alone. No previous trial of mineralocorticoid receptor antagonism has taken into account baseline extent of myocardial damage with significantly modified therapeutic response. And this study parallels the results of our preclinical studies in the dystrophic mouse model, which resulted in significantly more attenuation of cardiac pathology compared with later treatments. So now we are off on an open-label extension phase, and we're about to finish year 2 data collection, so that data will be out later this year. So we moved forward because we didn't see any identified risks and potential benefit. And we also felt that this is a disease, like many of the other people have elucidated during their talks, that has an evolution. And are we going to be able to impact the disease process long term, or is this just a short term benefit? And what does what we have seen really mean? So I think to carry this trial out further will be advantageous. And unfortunately, because of competing trials and the desire for families to participate in trials with potentially higher impact, we lost a significant subset of our first study subjects. However, we do have a cohort that's continuing on, and results will be later this year. So the next trial that's currently underway is a trial that's going to compare spironolactone to eplerenone, and because of the reasons mentioned previously with regards to the specificity of eplerenone and the potential for spironolactone to impact the glucocorticoid receptor, this is a non-inferiority trial with participants randomized to get one or the other. And what a non-inferiority trial means is that we're going to test whether the new product is not unacceptably worse than the product already in use. The primary outcome measure will be cardiac function, and the secondary outcome measure will be lung and arm function. And obviously, because of the effects that these drugs have potential on the glucocorticoid receptor, we want to do this trial in steroid-naive boys, which makes recruitment particularly difficult. So before I say thank you to the important people involved, I would like to make the comment of, I think the next question will be, well, should I put my son on eplerenone? And I think that that's an important question. But my response will be, I think to me as a cardiologist, yes, this drug does have some benefit. Now, we already knew that this drug had benefit in heart failure because of the vast experience that we have with this drug. Does this drug have some potentially added benefit in this patient population? I think that's yet to be seen. And so I would exercise caution. I would talk to your individual cardiologist with regards to where your boy is at, what types of symptoms, and what your boy's imaging looks like before making that decision. So I'd like to end by thanking all the study participants and their families, the research teams at all the sites, and our sponsors. Parent Project Muscular Dystrophy has been beyond supportive of this effort, and we are indebted to their efforts. We'd also like to thank Blue Skies, who's another foundation that supported this trial, and the National Institutes of Health. So thank you.